Hello there, welcome once more to this YouTube channel. Kindly subscribe to this channel. The topic is applied anatomy of the back. This is part 1 of this discourse. Now at the beginning I need to talk about caudal epidural anesthesia. Don't forget that the sacral hiatus is closed by a membranous structure we call the sacrococcygeal ligament. This is pierced by the filum terminale, and then the filum terminale is a connective tissue strand extending from the tip of the spinal cord to the coccyx. Deep to the sacrococcygeal ligament, you have the epidural space of the sacral canal, which is filled with fatty connective tissue. Now, in caudal epidural anesthesia, or what some call caudal analgesia, a local anesthetic solution or agent is injected into the fat of the sacral canal. This fat you find in the sacral canal is there, and it surrounds the proximal portions of the sacral nerves. So the anesthetic agent is injected into this area. You can do this by several routes, including the sacral hiatus, because the sacral hiatus is located between the corner of the sacral and inferior to the fourth sacral spinous process. That's the spinous process of S4, or you can find it around the medial sacral crest. So you can palpate, you can use this as a bony landmark to localize the sacral hiatus. So when locating the sacral hiatus, you can palpate the median sacral crest. So the anesthetic solution is injected and it spreads superiorly and extradurally. It acts on the S2, the remaining sacral spinal nerves, to the coccygeal nerves, and it anesthetizes the cauda equina. As a result, what happens after the caudal epidural anesthesia? You have sensation lost inferior to the epidural block. Anesthetic agents can also be injected through the posterior sacral foramina into the sacral canal around the spinal nerve roots. This form of anesthesia is called the transsacral epidural anesthesia. So if you don't want to do the caudal epidural anesthesia, you can also do the transsacral epidural anesthesia, where you inject into the posterior sacral foramina. You do that around by going into the sacral canal around the spinal nerves. You go through the posterior sacral foramina, and then when you do that, you are doing transsacral epidural anesthesia. I'm still talking about the applied anatomy of the back. I want to talk about abnormal fusion of vertebrae. In about 5% of persons, you find that the fifth lumbar vertebra, that's the L5, could be partly incorporated into the sacrum. And when that happens, we say there is hemisacralization or sacralization of the fifth lumbar vertebra, that is L5 vertebra. The illustration is right here. You can appreciate from this diagram that the fifth lumbar vertebra is fused with the sacrum. In others, you find out that the first sacral segment, S1, is more or less separated from the sacrum and is partly or completely fused with the fifth lumbar vertebra. And this is called lumbarization of the S1 vertebra, the first sacral vertebra. That is all illustrated right there. Next, I need to talk about injury of the coccyx. When someone falls abruptly on the lower back, you could have a very painful subperiosteal bruising or fracture of the coccyx. You could also have a fracture as well as dislocation of the sacrococcygeal joint. Displacement is common, and you could have surgical removal of the fractured bone. You could need to do that to relieve the pain. Very difficult delivery. In the process of delivery, when a woman has so much difficulty, at times the coccyx could be injured. A word about ossification of the vertebrae. Vertebrae typically ossify from 3 primary ossification centers, within a cartilaginous model. You have a centrum that will form most of the body, and then a center in each half of the neural arc. At the time of birth, you find out that most vertebrae consist of 3 bony parts united by hyaline cartilage. Fusion occurs during the first 6 years in a centrifugal pattern from the lumbar region. During puberty, you have 5 secondary ossification centers appearing. 3 are related to the spinous and transverse processes, while 2 other annular epiphyses around the superior and inferior margins of the vertebral body can be seen. You also have coastal elements formed in association with the ossification center of the transverse process. Usually, you have them formed from the ribs only in the thoracic region. So it's only the thoracic vertebrae that have this feature. They form components of the transverse processes of the thoracic vertebrae. Now, what are the effects of aging on vertebrae? Don't forget that during middle and older ages, you have an overall decrease in bone density and strength. This occurs very particularly centrally within the vertebral body. What happens as a result? The articular surface is gradually bow inward, such that you have the superior and inferior surfaces of the vertebrae becoming increasingly concave, and then the intervertebral disc become increasingly convex. The bone loss that occurs and the change in the shape of the vertebral bodies is a reason for the slight loss in height that you see with aging. So the slight loss that occurs with loss in height that occurs with aging actually comes from the effect of aging on vertebrae. Next, I want to talk about variations in the vertebrae. Most people have 33 vertebrae, but you could have developmental errors that result in 32 or 34 vertebrae. Now, a word about aging of the intervertebral disc. With age, you find out that the nuclear pulposi dehydrate. They lose elastin and protoglycans, and they gain collagen. You find out that the 2 parts of the disc appear to merge as the distinction between them become increasingly diminished. Then the laminae of the annulus fibrosus thickens with age and often develops fissures and cavities. That's some other feature you see with aging of the intervertebral disc. When you have a loss of disc thickness resulting in loss of height, it's seen as part of the aging process, and this accounts for loss of trunk stature, so the person appears to become shorter. It has been proven that the intervertebral bodies increase in size with age, such that disc height as measured in the center of the disc is normally maintained with aging. You find out that there are overt or marked cases of disc narrowing, especially when it is greater than that of more superiorly placed located disc. So when you see such, it might be evidence of pathology or aging. So when you see well-marked cases of narrowing of the disc, and you see that it is much more than what you have in more superior disc, it might be as a result of pathology, not aging. So you might need to do more investigation to find out what pathology you have there. Now, what about herniation of the nucleus pulposus? Herniation occurs as a well-recognized cause of low back pain and lower limb pain. The intervertebral disc in young persons are usually strong, so strong that the vertebra often fracture. You can see an illustration of the herniation of the nucleus pulposus right there. So the intervertebral disc, I said in young persons, are strong, usually so strong that the vertebra will often fracture during the fall before you find the disc rupturing. The water content of the nuclei purposi is usually high, almost as high as 90%, and this gives these structures great fullness. But in cases where you have a violent hyperflexion of the vertebral column, you could have rupture of an intervertebral disc and fracture of the adjacent vertebral bodies. Flexion of the vertebral column produces compression anteriorly and stretching or tension posteriorly. This squeezes the nucleus pulposus further posteriorly towards the thinnest part of the annulus fibrosus. So if the annulus, remember the nucleus pulposus is in the center, annulus fibrosus is in the periphery. So if the annulus fibrosus has degenerated, the nucleus pulposus may herniate into the vertebral canal and compress the spinal cord. The spinal cord, where you have the nerve roots of the cauda equina. So they could be affected, it could be compressed, and of course, what do you have? You could have pain from there. Herniations of the nucleus pulposus usually extend posterolaterally, where the annulus fibrosus is relatively thin and does not receive support from either the posterior or anterior longitudinal ligaments. A posterolateral herniated intervertebral disc is more likely to be symptomatic. It's more likely to give you pain because of the proximity of the spinal nerve roots, which are irritated, and then you have pain. The localized back pain of a herniated disc is usually acute. It results from pressure on the longitudinal ligaments and periphery of the annulus fibrosus. And then you also have inflammation caused by chemical irritation by substances from the ruptured nucleus pulposus. So this inflammation also results in pain. Chronic pain resulting from compression of the spinal nerve roots by the herniated disc is referred to an area of skin supplied by the nerves that are affected, that's the dermatome. Because the intervertebral discs are largest in the lumbar and lumbosacral region, movements are usually greater. You have posterolateral herniations of the nucleus pulposus, more common in the lumbosacral region because you have greater movement there. So posterolateral herniations of the nucleus pulposus is most likely to occur in the lumbosacral region. You find that approximately 95% of lumbar disc protrusions occur at the L4 to L5, that's between the 4th and 5th lumbar vertebrae, and also between the 5th lumbar vertebrae and the 1st sacral segment, that's L5 to S1 levels. Now let's talk about lumbago. What is lumbago? Lumbago is an acute middle and lower back pain. Lumbago is caused by mild posterolateral protrusion of the lumbar intervertebral disc at the L5 to S1 level, that's between the 5th lumbar vertebra and the 1st sacral segment. This affects nociceptive, that's the pain nerve endings in the region, such as those associated with the posterior longitudinal ligaments. So what clinical picture do you have? The clinical picture you see actually varies, but you could have pain of acute onset in the lower part of the back, that's very common. Then you could have muscle spasm associated with lower back pain. The lumbar region of the vertebral column becomes tense and increasingly cramped due to relative ischemia, that's the blood supply is affected, and this causes painful movement. So you have painful movement because of the cramps that result from ischemia. With treatment, what happens? The pain usually begins to fade within a few days, and if it's not well treated, it could actually progress and you have what we call sciatica. Sciatica is actually pain in the lower back and hip radiating down the back of the thigh into the leg. It is often caused by a herniated lumbar intervertebral disc. Such disc compresses and compromises the L4-S1 components of the sciatic nerve. The intervertebral foramen in the lumbar region decrease in size and the lumbar nerve increase in size. And that is why sciatica is so common, because as you're going more inferior in the vertebral column, you find out that the intervertebral foramina are reducing in size, while the lumbar spinal nerves are increasing in size. So it's as if the nerves are congested within the intervertebral foramina, so they get irritated and you could have sciatica. New bones, what we call osteophytes, are deposited also around the zygapophyseal joints. You could also have such as the posterolateral margins as a result of aging, and this may narrow the foramina even more. So in aged people, they have more problems to deal with. So they could have shooting pains that go down the lower limbs. In addition to the pain of sciatica, you could have more pains going down the lower limbs as a result of aging process, deposits of bone, osteophytes around the zygapophyseal joints. Now, let me mention the Koenig maneuver. It's a maneuver that stretches the sciatic nerve, such as when you flex, in the Koenig maneuver, you flex the thigh with the knee extended. So when you do that and you have some kind of pain, or you find out that pain is made more severe, you just discern that there is this herniation. So when there's this herniation, any pain that comes from this herniation, you can tell from the Koenig maneuver. When the person flexes the thigh with the knee extended, such pain is usually more severe. Even if the pain was not there at that moment, when he does such maneuver, the pain comes up. So you know there is pain coming from this herniation. Okay, now let's talk about injury and disease of zygapophyseal joints. The zygapophyseal joints are of clinical relevance because they are close to the intervertebral foramina, through which the spinal nerves emerge from the vertebral canal. So when the zygapophyseal joints are injured, or when they develop osteophytes during aging, in conditions like osteoarthritis, the related spinal nerves are of course affected. And what do you have? Of course, you're going to have pain. This causes pain along the distribution patterns of the dermatomes. And you also have spasms in the muscles derived from the associated myotomes. Recall that a myotome consists of all the muscles or part of the muscles receiving innervation from one spinal nerve. In such situations, what do you could do denervation of lumbar zygapophyseal joints. That is used as a form of treatment of the back pain caused by disease of the zygapophyseal joints. So when you're doing denervation of the lumbar zygapophyseal joints, the nerves are sectioned near the joints, or the nerves are destroyed by radiofrequency percutaneous rhizolysis. So you try to destroy the nerves. So when you destroy the nerves that were previously irritated and were causing the pain, the patient can have some peace of mind. The denervation is directed at the articular branches of two adjacent posterior rami of the spinal nerves, because each joint receives innervation from both the spinal nerve that exits that level and the subsergent nerve. So you have to, when you're doing denervation, you have to keep that in mind. You denervate the articular branches of two adjacent posterior rami of the spinal nerves for you to actually denervate a particular joint. Next, I want to talk about fractures and dislocations of the vertebrae. Although the vertebral column is such that it permits a considerable amount of movement, you also have support and protection that is given by the ligaments. When there's excessive or sudden violent movement, or a kind of movement that is not permitted in a specific region normally, you could have resultant fractures, dislocations, and also combination of fracture and dislocation of the vertebral column. Sudden forceful flexion, for example, as you have in automobile accidents or from a violent blow to the back of the head, could result in a crush or compression fracture of the body of one or more vertebrae. If you have violent anterior movement of the vertebrae, and this occurs in combination with compression, what happens? A vertebrae may be displaced anteriorly, and such vertebrae is displaced anteriorly on the vertebrae inferior to it. So it slides anteriorly on the vertebra inferior to it. So you could have dislocation, for example, of the 6th cervical vertebra or the 7th, and it could be displaced and go anterior to the one inferior to it. Usually this kind of displacement dislocates and fractures the articular facets between the two vertebrae and ruptures the interspinous ligaments. You could also have irreparable injuries to the spinal cord, which accompany such severe injuries to the vertebral column. So the spinal cord could be severely injured, and you wouldn't want to know what happens after that. You could have some kind of paralysis in some parts of the body, depending on what part of the spinal cord is affected. When there is sudden forceful extension of the neck, you could have injury of the vertebral column and spinal cord, like when you're doing head butting or illegal face blocking in football, for example. This could cause hyperextension injury. It could result in hyperextension injury of the neck. When you have such severe hyperextension, you could have injury of the posterior part of the vertebrae, and this could result in fracture or crushing, compression of vertebral arches and their processes. Fractures of the cervical vertebrae could cause pain that radiates to the back of the neck and the scapular region, because the spinal accessory ganglia is affected and the spinal cord segments are also affected, and this receive pain impulses from the vertebrae and are also involved in supplying back muscles. Hyperextension injuries are called the whiplash injury of the neck. They could also occur during automobile accidents. In this type of hyperextension injuries, the anterior longitudinal ligament is severely stretched and it could be torn. Hyperflexion injury of the vertebral column also occurs, and it may occur as during head rebounds after hyperextension. You have a rebound and you now have hyperflexion, snapping the head forward onto the thorax. Now I'm going to talk about curvatures of the vertebral column. The vertebral column in adults has 4 curvatures: the cervical, thoracic, lumbar, and sacral. The thoracic and sacral curvatures are called kyphosis, that's they are concave anteriorly, while the cervical and lumbar curvatures are called lordosis, they are concave posteriorly or convex anteriorly. The thoracic and sacral curvatures, these curvatures are illustrated right there. You can see the kyphosis and the lordosis all illustrated there. The thoracic and sacral curvatures are primary curvatures because they develop during the fetal period in relationship to the flexed fetal position. The primary curvatures are retained throughout life as a consequence of differences in height between the anterior and posterior parts of the vertebrae. The cervical and lumbar curvatures are secondary curvatures, and they result from extension from the fetal flexed position. These secondary curvatures begin to appear during the fetal period but do not appear obvious until infancy as the child develops. Secondary curvatures are maintained primarily by differences in thickness between the anterior and posterior parts of the intervertebral disc. The cervical curvature, which is one of the secondary curvatures, becomes fully evident when an infant begins to raise that extend its head while prone and to hold its head erect while sitting. So as the infant begins to sit down, you have the cervical curvature obvious. So it begins to develop and then you can appreciate it. Then the lumbar curvature becomes apparent when an infant begins to assume the upright position, standing and walking. This curvature generally is more pronounced in females, and it ends, that I'm talking about the lumbar curvature, the lumbar lordosis. It's more pronounced in females. You appreciate it, it ends at the lumbosacral angle, which is formed at the junction of L5, the fifth lumbar vertebra, with the sacrum. The sacral curvature also differs in males and females. That of the female is reduced so that the coccyx protrudes less into the pelvic outlet. We like it that way so that we have more room during birth, childbirth. The curvatures, that's the curvatures you find in the vertebral column, provide additional flexibility. It makes the vertebral column flexible, and then it gives some shock absorbing property to the vertebral column. It further augments the shock absorbing property that the intervertebral discs are affording there. When the load borne by the vertebral column is markedly increased, both the intervertebral disc and then the flexible curvatures are compressed. That is, the curvatures tend to increase, they become more pronounced. Now, more importantly, you have the abnormal curvatures of the vertebral column. Abnormal curvatures, you find it in some people, resulting from developmental anomalies. In others, the curvatures result from pathological processes. Right here is an illustration of the abnormal curvatures of the vertebral column. The most prevalent metabolic disease of the bone that you find in the elderly, especially in women, is osteoporosis. In osteoporosis, you have net demineralization of the bones caused by the disruption of the normal balance of calcium deposition and resorption. What happens after that? The quality of bone is reduced and you have atrophy of skeletal tissue elements. Osteoporosis affects the entire skeleton. The most affected areas, however, are the neck of the femur, which is the thigh bone, the vertebrae, the metacarpals, that's the bones of the hand, and the radius bone of the forearm. All these bones become weakened and brittle and are subject to fracture. So when the vertebrae are affected, you to result in abnormal curvatures of the vertebral column in the elderly. The first abnormal curvature of the vertebral column that I must talk about is excess thoracic kyphosis. Excess thoracic kyphosis. Some tend to shorten it to mean kyphosis, but kyphosis is actually a normal curvature you have in the thoracic region. So, what happens in excess thoracic kyphosis, what we call the humpback or hunchback. In excess thoracic kyphosis, you have abnormal increase in the thoracic curvature. The vertebral column curves posteriorly, more posterior curvature of the vertebral column. So this abnormality can result from erosion of the anterior part of one or more vertebrae. For example, an abnormality caused by osteoporosis. So osteoporosis could cause excess thoracic kyphosis. The Wager's hump is the name you give for excess thoracic kyphosis in older women with osteoporosis. Excess kyphosis also occurs in elderly men as well. Osteoporosis affects the horizontal trabeculae of the trabecula, that's the spongy part of the bone of the vertebral body. So you have the remaining unsupported vertical trabeculae, which are much less able to resist compression, and what happens as a result, you have compression fractures, and you now have a resultant wedge-shaped thoracic vertebrae. You have resultant wedge-shaped thoracic vertebrae. So when you have progressive erosion and collapse of vertebrae, you have an overall loss of height in the individual. And the excess kyphosis leads to an increase in the anterior posterior diameter of the thorax. What about excess lumbar lordosis? Right here is an illustration of excess lumbar lordosis, and you have, some people call it lumbar lordosis, but it's actually excess lumbar lordosis that is the pathology here. You could also refer to it as hollow back or sway back. In excess lumbar lordosis, you have an anterior rotation of the pelvis, that's the upper sacrum tilts anterior inferiorly at the hip joint, producing an abnormal increase in the lumbar curvature. The vertebral column curves more anteriorly. This abnormal extension deformity is often associated with weak trunk musculation, especially the anterolateral abdominal muscles. So to compensate for alterations to the normal line of gravity, women develop a temporary excess lumbar lordosis during late pregnancy. So you have women having excess lumbar lordosis in pregnancy, especially in late pregnancy, where because of hormonal changes you have relaxin. It makes the ligaments to be loose, freer, and then the pelvic cavity becomes wider, and then you have the center of gravity changing. This lordotic curvature may cause low back pain in such women, but the discomfort normally disappears soon after childbirth. Also, obesity in both sexes can also cause excess lumbar lordosis, and low back pain also results because of the increased weight of the abdominal contents, like you find out in men with pot belly. So loss of weight and exercise of the anterolateral abdominal muscles facilitate correction of excess lordosis that results from obesity, for example. Next, we need to talk about scoliosis. Scoliosis is right there, as you can see. It's also called crooked or curved back. You have an abnormal lateral curvature that is accompanied by rotation of the vertebrae. When you have scoliosis, you notice that the spinous process turns towards the cavity of the abnormal curvature, And then when the individual bends over, the ribs tend to rotate posteriorly. They protrude on the side of the increased convexity. Scoliosis is the most common deformity of the vertebral column in pubertal girls. That's girls. These girls are aged between 12 to 15 years. You have a symmetrical weakness of the intrinsic back muscles. In that case, you call it myopathic scoliosis. There is failure of half of the vertebrae to develop. You call it hemivertebra. And there's a difference in the length of the lower limbs. All these are causes of what? Scoliosis. So if the lengths of the lower limbs are not equal, you have a compensatory pelvic tilt, which leads to a functional static scoliosis. So the individual now develops a compensatory gait, and then you have a functional static scoliosis. When a person is standing, an obvious inclination or listing to one side may be a sign of scoliosis that is secondary to a herniated intervertebral disc. So when you look at an individual standing and it seems as if he's inclined to one side, that is a scoliosis, most likely caused by a herniated intervertebral disc. You also have habit scoliosis, which is caused by habitual standing or sitting in an improper position. Some of us have very bad gait when standing and even sitting. So when you do that habitually, you could have habit scoliosis. Then when the scoliosis is entirely postural, it disappears during maximum flexion of the vertebral column. So when you ask an individual to flex the vertebral column, it does that to the maximum extent. When you see that scoliosis disappears, you know that is what? Postural scoliosis. Sometimes there is kyphoscoliosis, where you have a combination of excess thoracic kyphosis combined with scoliosis. We have said so much now. Don't forget to subscribe to this channel. Thank you for listening. Goodbye for now.